Natasha, I think we can start.
Principal, Louise had indicated that you are going to introduce the speakers and I mustn't read anything.
Yeah, okay, let me start.
Okay.
Good afternoon, colleagues. Good afternoon to you all who are attending this NSG masterclass today. On communicating pandemics, we are hoping to have a very exciting 2 hours with all of you this afternoon. We've got very distinguished scientists and the public policy practitioners who are joining us today. That is in the form of Dr. Nona Simolila from World Health Organization. She's well known to some of you here in South Africa, as well as Professor Musa Mushabela. Some of you might have interacted with him in the
Principal, I'm not hearing you. I don't see you. I see you talking, but I can't hear you.
Louise, we can hear him. It might be your connection.
Yes, so we both of them have agreed to come and interact with us today. It's a very unique masterclass, this one, in a sense that we've got the 2 scientists who will be talking. We've got government communicators. We also have media practitioners who are invited here. The idea is that we build a bridge between science as well as we build a bridge between science and public health promotion. I'm not going to read their profiles. They are here. We will also dump them on the chat platform for all of you to see. So we are going to remove what you are seeing currently on the screen. As the National School of Government, we are excited to have all of you here. My colleagues, Natasha and Louise, are the ones who will be directing the program. They will give you the instructions of how the system will be working. Marty will give me the right to share. I must do some marketing as a National School of Government, as a government department which is self-funding. So every opportunity we make, we must do some marketing of the school and what we do and what we do not do. So as you are aware, we've been doing a lot of masterclasses. You might have attended some of them recently. Masterclass series are important for the National School of Government because, as I said, we're able to bring experts and knowledge into public sector employees. We call them public sector employees because the National School of Government is open for everybody who works in the public sector or organs of state, except for members of the judiciary. So all the programs we run, everybody is welcome, including those in universities. It's part of the public sector, so they can also enroll for our programs. And these are the type of masterclasses series that we are running, so you can tell that we mean business by the type of people, high-profile people that we are organizing. Even the President of the Republic has attended and has been a student in the masterclass of the NSG. Today, this is the masterclass that you are attending, and thank you for being here to engage with the 2 esteemed members of the scientific community that we are bringing to you. And we've had other masterclasses on dealing with the COVID pandemic and how it is impacting on the world of work, and hopefully you will be coming to join us for other masterclasses. Not just masterclasses, but you must also enroll for our flagship programs where we need to make some money so we are able to pay and meet our obligations as the NSG. We've got very exciting programs working through partnerships locally and internationally, because partnerships are the future for us. For those of you who have not done a program called the Nyukela, which is a compulsory entry exams for everybody who wants to work in senior management in government, we encourage you to go to our website and register for Nyukela. Even if you are a DDG, you are not eligible for an appointment as DG unless you have done that exam called Nugela. If you come from outside the public sector, enrolling for Nugela will do wonders for you, because it will help you do the transition from the private into the public sector. We are hoping that through these interactions that we are doing, we will build a new cadre of public sector, managers, and leaders who will do in a manner in which we have displayed here. People who can exercise leadership, lead by ideas and not rank, design and implement, innovative digital transformation programs, and also engage in high-level financial planning and budgeting, as you know that we are moving towards a zero-based budgeting arrangement. Finally, for those who are public servants, our motto as a National School of Government is we use platforms like the masterclass and other programs we have to expand learning opportunities for you so you can master statecraft. We also are building this capacity in the public sector so that people can serve much more effectively. And lastly, everybody needs to grow professionally. So we're helping that through these arrangements, you will be able, as a public sector, employees and leaders to grow in the work that you do. Thank you very much once again for being here. Over to you, Natasha.
Thank you, everyone. And thank you for joining us today. Just as a matter of housekeeping, thank you to those who have submitted their questions. I have posted a comment in the chat to say that those people who have submitted your questions, I appreciate it. Sorry about that. However, we are still obviously accepting more questions during the session. If you can please try to keep your questions short and concise, I'd really appreciate that. I'd like to also introduce our first speaker, Dr. Nona Simolila. Dr. Nona is from South Africa. She's been appointed Assistant Director General for Family, Women, Children and Adolescents at the World Health Organization. Dr. Simolila has more than 30 years of experience as an obstetrician. She's an academic, advocate, as well as a government official. So I would like to hand over to Dr. Simolila.
Thank you. Thank you, Natasha. Claire, if we can start. Okay. Let me start by also thanking the principal of the National School of Government. I must upfront put a disclaimer here, or expose myself and Sani that we have a very long relationship, and we've worked hand in glove in many areas of government, but I think the one area that stands out very freshly in our minds is when our country was faced with the HIV epidemic. And I think for those of you who remember, you must know that the role of communicators at that time was very, very complex. I think it's very appropriate at this point in time to have such a webinar, because even though we've been a year into this pandemic, we still have a long way to go. So I consider you as part of the solution. I consider you as foot soldiers of the government of South Africa. And I hope that as soldiers, you have learned as much as you can about the war that we are fighting, about the enemy that we are facing. And if you haven't done that, I think you actually create a very big gap. You become the weak link in the system, and you do yourself a great disfavor if you do not learn about this. And I hope today, myself and my colleague, Prof. Musa, will do something, add value, maybe teach you a few new things, or share. You know, it's not it's a class, but it's not a typical class. Share with you, and you will see as we present that there is a nice contrast here. You'll see age against youth, or age and youth contrasted, in that Prof has a very colorful presentation, which shows the move towards the love of color by young people, and the move towards being older, as exemplified by myself, and staying away from very complicated things. So I hope I haven't been too long, but I hope that that sort of sets the scene for us for today. So as a representative of WHO, I will use many of the tools that that institution has developed, because as you know, WHO has led the global response to the COVID-19 pandemic. We've made errors, we've made mistakes in some of the things that we have done, but we have also managed to corral the biggest number of scientists and stakeholders to just come together to focus their energies, their knowledge, their skills on defeating this one pathogen, the SARS-CoV-2. So in the realm of infectious diseases, pandemics are your worst case scenario. When an epidemic goes beyond the borders of a country, it's officially a pandemic. And when a disease has episodic events in a community, we call that an endemic disease. These are terms that people must be familiar with, because I'm sure one of your colleagues or somebody in an audience that you might be addressing will say to you, but why are we not calling this an epidemic? Why are we not calling this that or the other thing? I think this is very important that you know. But it is not only a pandemic. I think it's important to also share that when an event like this happens, there are rules and regulations that have been put in place by the World Health Organization called International Health Regulations, which compel and or put the onus on countries to declare or to inform WHO about events that are unusual, that may create a public health emergency. And you know now that COVID-19 is what we call a public health emergency of international concern. Unfortunately, the acronym is fake, and we don't really want to use it a lot, because this is not about fake news. This is the reality, in that we have already lost millions of people. So throughout my presentation, I'll touch on communication, the challenges that we face together as scientists, as clinicians, as ordinary citizens, yourselves as communicators, when it comes to what do we say, how do we say it, and to whom do we say it, and for what purpose. I'll talk a little bit about trust and why it is important in the mix of communication and responding to a pandemic. I want to touch also on public concerns, because often when there is an emergency and there is urgency in responding to that, public concerns tend to be left on the periphery, and that is where the problem might arise. So every single concern that the public raises is important and must be responded to. And if you are the communicator who is now the interlocutor between the citizens and the state, you have to carry those concerns as expressed by the citizens to your leadership so that they must be addressed. I'll touch on the role of the scientific community, which is something that is very important. And I know that my fellow panelist, being an infectious disease specialist, will also delve into this space and demystify some of the things that we love to say as scientists. The principal alluded earlier to issues like efficacy and effectiveness and things like that. These are terms you have to know because these help you become a better soldier as you work with government and with communities on this pandemic. Then I want to open a little window into the future as to what it is that we might expect. What can we do about what is on the horizon? What can you do as communicators to arm yourself for what is coming? And what are the best tools at your disposal to make sure that you always are communicating the right message to the right audience at the right time? Next slide, please, Clem. Now, to start with pandemics, we know that although we are living in the middle of one right now, it feels like a unique experience. It's unique to us because, yes, it's a first. It's unique to us because, yes, this is a new virus, but humans and viruses and pathogens have coexisted for many, many decades, and in some cases for centuries. The first pandemic actually occurred between the 6th and the 8th century. So these things are not new. And we need to bear in mind that it is in the best interest of the virus to live, which is why it does a number of things. It changes its shape and form, something that we saw happening in South Africa. It might change the way it moves between people, which then increases its pool of people that it can infect. And it might do other things, jump to a different host to evade the vaccines that are on the horizon. And therefore, we must not minimize the impact of these pathogens. They are so small, we can't see them, but they wreak havoc. And at the rate we are going as humankind, I can easily say that the pathogens have outpaced us. They have outlived us, and they will outlive us because of a few reasons I'll highlight in the next slide or so. So on this slide, I've just tried to share or remind you of some of the pandemics and epidemics that have happened, that have impacted significantly on humankind, and just to compare the number of people who died in the context of these epidemics. I'll pick on the Spanish flu because this is the closest one to us, although it happened during World War. It's something that we always refer to. What happened with the Spanish flu? What caused it? Why did so many people die? And what was done about it? Obviously, at that time, we didn't have many, the scientific innovations. We did not have many of the interventions and the therapeutics we have now. We didn't have the know-how. And the world was in the middle of another urgent issue, which is a war. But that pandemic is estimated to have killed between 20 and 50 million people. Now that's a lot of people, considering the size of the population on the planet at that time, or on the globe at that time. And those are estimates because, as you often hear, there is often and there will be excess mortality. We are burying people who have died from COVID at a very quick rate in South Africa. Some people are dying without their diagnosis being confirmed. Some die without even reaching the clinic or the hospital. And therefore, you will find that there are many more people who have died from COVID-19, much higher than the numbers that we see daily that are released by the Department of Health. And that is to be expected. And then you can see also how other pandemics affected the countries of origin as well as the populations. And as a comparison, COVID-19 has to date, as of March 2021, killed 2.8 million people, which at this time is what? 0.04% of the global population. So we do have an advantage, although I said that these pathogens have outpaced us in the scientific developments that we have. Next slide. Let's talk about communication. As communicators, I think you know, by having chosen to be a communicator, that under normal circumstances, communication is fairly simple. When you are communicating about an upcoming event, either in a department or any part of government, it's not so complicated. Even when we are communicating sad news like the passing away of a stalwart or someone like that, it's not complicated. It's sad, but not complicated. But when we are talking about a pandemic, the stakes are high and it's very, very complex. So you really have to understand that first and foremost, you're communicating about an unpredictable situation. So how do you deal with the fact that you are standing in front of people and you yourself are not entirely sure about what you are going to say, and as you say what you say, the situation changes immediately. And then you have to either withdraw what you've just said or just say, we have new information. This has happened many, many times in communication or during communications, especially media briefings in WHO, where in the middle of a presser, the Director General gets given the latest update on something, and it just contradicts something he just said 2-3 minutes before he was given that information. The best way of dealing with something like this is to be transparent about what you know and be honest about what you don't know. Say to people, we are still awaiting the latest information from the scientists or from whoever, and we will update you as soon as new evidence arises. This is not a sign of not being clever or not being on top of your game. It's an honest approach to communication, and it actually garners more respect for you as an individual, respect from your peers and from the community. And it builds on the very important ingredient of communication, which is trust. The second thing about a pandemic, as I said, is you are communicating about something that is unknown. You are communicating about an emergency. So it's not just that you are telling people there is a pandemic. In fact, it's a life and death situation. And people are expected to do something, do it immediately to save their own lives or to save the lives of the ones they love, of the ones closest to them, or the lives of people in the community. That makes your responsibility doubly important, or very, very important, because if at that point you communicate something that is not factual, you might create a ripple effect in the community, which you will be held accountable for. So even when the facts are not completely known, you still have the responsibility to communicate. Stick to what you know, as I said, admit what you do not know, and provide updates as the pandemic evolves. It's often said that nature abhors a vacuum. So if you remain silent, people will make things up, and those will become truth. And then you have to write a counter statement to try and dispel the myths that other people have created because, well, you've been silent and they are bored and they just want to create chaos in the community. Now with social media, all of us in South Africa know how this has panned out in the context of this pandemic. And in addition to all these things, the fact that I'm South African, although I haven't been in the country for the last year, I could see how the communications environment was also complicated by the politics. It was complicated by many other sectors and factors that are not often part and parcel of many other countries that are as democratic as we are. And I'll also just give a shade of what it's like to live in a democratic state and in an autocratic state. What are the pros and the cons? So that maybe you appreciate the circumstances and the environment in which we live as South Africans, as opposed to some of the things we saw happening in countries that we have looked up to as being the richest, the most civilized, etc., where chaos reigned supreme in the context of this pandemic. I spoke about whether or not public concerns are important. I'll come back to the opportunities. Public concerns are very, very important, especially when you are dealing with a disease that moves from person to person or that is transmitted from person to person. So you've got to be very, very clear with your facts and take the response of the public seriously. I'll just pull again on another example where we made a mistake as WHO. We were too late to pronounce on the use of masks, and we were roasted over it, because if we had pronounced earlier, although we kept saying there isn't enough evidence, if you look back at some of the pandemics that I've shared with you, you will see that with the Spanish flu, people were wearing masks. They were wearing protective equipment, whatever it was in that era. But it was very difficult to understand why we, as the topmost institution on health and on public health especially, took such a long time to pronounce on that. We also got very confused about aerosol transmission, this and that, and it was up and down, and everybody started to make a joke about this. And it was not the right thing, because the more mistakes and errors we make, the higher the risk of more people dying, because we haven't verified, clarified, read and reread the facts or the information or the evidence that was put in front of us. When you communicate, keep things simple. Keep things very, very simple in such a way that people understand. And if you are communicating beyond a health impact, like we have had to do now with this pandemic, it has had an impact on people's social lives, the economy of the country, the cultural issues, the beliefs that people have and hold deeply, you know, when we've had to change how we bury our dead and our loved ones, it becomes more complex, and it then becomes political. And once it becomes political, it is a place where only the bold dare go, you know, because once the politics plays its role, you actually lose even the story, you know, what was the issue in the first place? Because now you have layer over layer over layer of issues and complaints and all sorts of things, hiding the original reason why the country is in a state of disaster. So you as a communicator have to filter the facts, filter the information, stay as neutral as you can be, and communicate the facts as far as you know them, as far as you can verify them. And we have seen how this pandemic has been heavily politicized. We are seeing now how equity and equitable access to vaccines has become a very serious challenge, where countries in the North have pledged solidarity, and yet one country that I know, that I will not name, has 5 times the number of vaccine doses that it needs for its population, when at this point in time in South Africa, we have very little. And in some African countries and Latin American countries, there isn't even a single dose. Now, that's the politics. It's the politics of the game, and it's got to do with very simple things. Profit for those that are producing the vaccines, and all the other things that have to do with fights across borders, geopolitics, as it were, and everything that I wouldn't even be able to summarize for you, which we observe in WHO, where countries use their might, their weight, and everything else to push their weakest out of the negotiating room or from the negotiating table. This is the reality. You also have to understand that people will panic. So plan for panic when you are communicating around something like COVID-19. At this point, I think people are no longer panicking because we've got hope. We know that something has been found that will help mitigate, not cure, not remove this virus from all of us, but these things will help. But people will always panic. Every individual who's living in the middle of a pandemic like we are, we panicked. We are panicked still now. We're a little bit complacent now, but you know, when you were standing behind someone in a queue who wasn't wearing a mask, I'm sure many of you got tempted to either clobber that person on the head or to pull their mask up to cover the nose. So this is panic, and it has to be anticipated. And we have to be firm about those things that we know contribute to decreasing the chances of transmission as communicators. So you have to be prepared to stand on a public platform and call out people who are not wearing masks and say, here you are in this gathering, we are not social distancing and we are not wearing masks, even if it's members of your family, because this is how you show love towards them. It's not about creating complications for how they live their lives. So these are the things that I think as communicators you have to be alive to. It is not just about the facts. We are not just a post office where information gets put inside you and you just transmit it as it is. You are also a human being living in the middle of a pandemic. You've got loved ones, you may have lost a few, and therefore you've got to communicate with soul and concern so that people trust you, they take you, they treat you with respect, and they believe what you are saying. Next slide, please. Some of the solutions, not all of them, that we propose to manage uncertainty are on this slide, and I've really spoken about them. When you don't know something, don't pretend that you do. When you make a recommendation and you are not sure about it, qualify what you are saying. Promise people that you will update the information. Encourage citizens to stay informed and inform them where to find credible and reliable information. We've got 11 formal languages here in this country. It's very, very difficult to keep everybody on the same page or informed every time, all the time, 24/7. It's very, very difficult. So this is something that you have to find ways around to enable you to be the best representative in terms of communications in the middle of a pandemic. And the other thing, the last point I'll make is do not make promises in the context of uncertainty. Don't say in a couple of months everything will be back to normal. We don't know. This pandemic may last another 2 years. Who knows? It might last another year. You know, last year we said 2 years. Now we're in the second year. And these were those of us who were looking at the Spanish flu and saying, oh, those people were archaic, they didn't know what to do. Now we have science. Oh, I'm sure next year we'll be fine. Well, it's 2021. And from what we are seeing, there are countries that are already entering the third, fourth wave of this pandemic, or waves of this pandemic, and there's still huge shortage in terms of vaccine supply. Next slide. This is still more about managing uncertainty, and I deliberately put this slide in here, although it might not be something that you deal with directly as communicators. But the issue of panic, uncertainty, urgency, death, all of these things. And on top of that, the lockdowns and everything that has happened contributes immensely to mental well-being. So as part of being a communicator, keep that in mind. And when you look at what you are going to say, do not exaggerate. Don't create drama. Try to speak in a way that does not create false certainty, or if there's anything like that in the English language. But always bear in mind that there is a huge mental health impact on people. There has already been, for the last year, a cumulative effect, which will take a long time to deal with. And part of the reason I say that this pandemic is going to last much longer than we think is because although we have a great recovery rate in South Africa, really in the 90s, the after effects, the impact on those people who have survived COVID-19 has yet to be known on the different parts of the body, on the brain and everything. There's a lot of research that is ongoing. Some scientists, clinicians, and researchers are really picking up very worrying conditions. So you can imagine that the burden of non-communicable diseases as a result of this pandemic is going to increase significantly, and that puts further pressure on our system. So I really, if you remember nothing about what I've said today, bear in mind or always think about the mental health impact of this very significant pandemic. Next slide. The role of the scientific community. This is something I really like to talk about, because as scientists, and as the principal mentioned, we really get lost in our own little world. We use language that people don't understand. I remember even with the HIV epidemic, you know, we had great difficulty translating the science into ordinary language that people could understand. We really struggled. And it's very important, I think, that we meet each other halfway. Scientists must simplify concepts, and we as communicators must also meet the scientists halfway by asking them provoking questions, by asking them questions, explain this in a simple way, in a way that I will understand, because I'm a communicator and I'm going to talk to a granny on the outskirts of Soweto who doesn't understand why she has to come out of her house on a cold May day to come and be vaccinated, you know? Why must I come out, and what is this thing that you're going to put in my arm? Is it this thing not going to cause me to die? Look, I've lived until I'm 80 and 90. Now you want to kill me with this. Even your COVID-19 didn't kill me. Now you want me to die because of your vaccination. So we've got to be prepared, and we've got to be simple. I took the liberty of using a very short clip from one of our scientists, and I would love your feedback when we have a discussion later about what it is that you picked up as she spoke. We can't hear her. Volume.
How do vaccines work to protect us? And what are the different approaches that we are hearing about now for vaccines? Hello and welcome to Science in 5. I'm Vismita Gupta-Smith, and this is WHO's Conversations in Science. Explaining this and more today is WHO's Dr. Catherine O'Brien. Welcome, Kate.
Thank you so much.
Kate, explain to me how vaccines work with our body to protect us.
Vaccines, what they do is they are a part of the germ that our body can recognize and develop an immune response to, so that the next time that we see the real germ, there are already fighters in our body to protect us against the infection. For coronavirus, we know that it's a part of the outside of the coronavirus. The spike protein is the part that if we have fighters against the spike protein, we will have a much lower chance of getting disease or getting serious disease from coronavirus. And the fighters that what I'm speaking about, those are called antibodies. It's the part of our immune system that is the part that can attack that particular part of the virus.
So we're hearing about different terms like mRNA and different approaches. Explain that, please.
So all of the vaccines are ultimately trying to do one thing. They're trying to get that part of the virus, the spike protein that I just spoke about, into the body so that our immune system can develop antibodies against the spike protein. And there are two big categories of approaches to do that. The first approach is just put in the vaccine part of the spike protein or the spike protein itself. And the second category is give the instructions for how to make the spike protein and let the body produce the spike protein. In the first group, where we actually give part of the spike protein, this is how the vaccines that we have for lots of other diseases work. And sometimes the vaccine is developed so that it has just that part of the germ in it, in this case, the spike protein. And in other cases, what is given is a highly weakened or even killed version of the virus that still has the spike protein on it. So there are different strategies within that first category of giving the spike protein. In all cases, it is so weakened, the particles that are given, that they don't cause disease in us. So you're not going to get disease from the vaccines that are given, even if it's a weakened part of the germ. This second category, where we're giving the instructions to the body on how to make the spike protein, this is a new strategy that's being used. And it's a really important new strategy because we can develop vaccines very quickly, a much more efficient way of developing vaccines and using the body's own ability to produce proteins is a really powerful tool.
Kate, when we hear about vaccines developed from parts of viruses, people may have questions about safety. Speak to us about safety of these vaccines.
Our immune systems are incredibly powerful. On a daily basis, a weekly basis, a monthly basis, our immune systems are seeing all kinds of viruses that come at us in our noses, in our mouths, in our intestinal tract, on our hands. And it's their job, it's the job of the immune system to be surveying what's out there and readying itself for when it's exposed to something that could be causing disease. What the vaccines do is they provide to the immune system a small part of a germ that we know can cause disease. And it's training the immune system so that it is completely ready when it actually sees that particular germ. The vaccines that we have that have been used in hundreds of billions of doses for decades, and in fact for centuries for some of the vaccines, have been studied, evaluated for safety and for the impact that they have. And we have a safety system for all vaccines that is constantly looking at the information about the performance of the vaccines and picking up any issue around safety that might arise in the future. So I think we can be really well assured that we have a very strong system in place to both look at safety, assure safety before a vaccine is authorized for use, and will continue to monitor safety even after it is deployed for widespread use.
There you have it, Dr. Catherine O'Brien explaining how vaccines protect us. Remember, there is a lot of misinformation about vaccines out there. So please share this information with your loved ones, with your friends and your networks, and be the source of scientific, evidence-based information. Until next time then, stay safe, stay healthy, and stick with science.
Okay, Kat, thank you. So my last input is one sentence that I want to share with you. By choosing to be a communicator, as I said, you've opted voluntarily to be part of the foot soldiers on the ground. You must take this responsibility very seriously. For those of us who are clinicians, we know that when we make mistakes, often it leads to the loss of lives. Consider your responsibility in the same way, because if you translate or you give people wrong information in the context of a pandemic, that can very easily translate into the loss of many, many lives. So I hope that you are ready for the fight that's still ongoing, and that you have picked something up from our scientist and researcher, Kate O'Brien. I will not say anything. I will just hand over to my panelist, whom I wanted to provoke when I said that we are going to have many, many waves, many, many phases, many, many mutants and variants of this pandemic. And I know Professor Musa is going to tackle that in his presentation. Thank you very, very much for listening. And I'm sorry, I really, really took a lot of time sharing with you. Thank you.
Thank you very much, Dr. Simolila. I'm going to just start with some questions. Or a chair, is there a formal response that is coming at this point, or can we just cut to questions?
Yeah, we can move to Prof. Musa immediately, yeah. Then we'll give you the questions together after that.
Oh, okay, great. I will do so. Okay, so thank you very much, Dr. Simolila. That was a wonderful presentation. So what I will do is I will collate all the questions then and then share with everybody in plenary. Okay, so Professor Moshapela currently holds the position of Associate Professor and Deputy Vice Chancellor of Research and Innovation at the University of KwaZulu-Natal. He was until December 2020 the Dean and Head of School of Nursing and Public Health in the College of Health Sciences. Professor Moshapela, if you can share your screen.
I have, thank you. Good afternoon, colleagues, and greetings to everyone present. I also want to start by thanking the principal for the invitation and the National School of Government for this presentation to be at this event, and also to thank Dr. Nona for helping with that. I really appreciate it. And I should also then just thank you in advance for having to put up with my ramblings for the next few minutes. I should also maybe give a disclaimer that I am not a trained communicator and therefore not an expert in communication, but I will share my experiences and lessons, and then we can take it from there. As we're talking now, and I think that Dr. Nona has already given set the scene in terms of the broader issues concerned here. I do want to highlight the fact that there is communication and public health communication in what we would regard, for example, as peacetime or normal times. Then there's also communication in public health emergency, as we've already been told. And as you've heard, in this set of circumstances, we often look at it as communication during wartime. Now, for me, at the end of February last year, I started the war room against COVID-19 at the University of KwaZulu-Natal. And at the time, it was when we launched, it was on the 3rd of March. It was before we had our first case. We had our first case on the 5th of March. And for that reason, I was criticized for launching a war room. One, I was told that, are we not overreacting? And secondly, I was told that, why are we using war language? But subsequently, of course, many people then began to understand that it's almost like we are in wartime. And even many of the provinces also set up war rooms and became comfortable with the use of that language. Dr. Nona has also referred to you as soldiers. And even though, we are fighting an enemy we cannot see, many of us accept that the state we are in is almost like in wartime. Now, if we are in wartime, then one of the things that becomes really important is communication, command. And that's why we've got all these command councils nationally and provincially. And also in terms of initially centralizing communication like the minister did and the president do in the country. And so I want to put that scene in your mind and basically give you that to think about as we unpack the processes around communication. I'm not going to dwell a lot on content right now. We can talk about content when we discuss, but I want to talk about the processes, sharing my own experiences of what I observe in the background of communication so that you can start to think about these things. I'm going to start off with something that you are familiar with, which is communicator models, or at least I assume that you're familiar with. Then I'll talk about learning and the levels of learning. And this will start to address some of the questions you're asking about how to filter facts and how to navigate facts. And then I'll talk about the goals of communication. And again, I'll also be provoking you a little bit around these things and talk about transformational models, the goal of societal impact, and people-centered communication, which is something that, for me, if there's anything that you can take from this presentation today, it would be this idea of a people-centered approach, because it is the one thing that helped anchor me in the last year in the way that I've been engaging in communicating public health information around COVID-19 in social media, in mass media, and also in trainings and talks that I've done. And I'll explain also why this helps me a lot when I talk about this notion of positionality. As you'll see, how are you positioned as someone who is doing the communication? And Dr. Nona referred to it, that you need to be neutral. What does that mean? How do you achieve that when you have your own views, you have your own beliefs, you have your own level of knowledge, concerns, fears, you have your own mental distress, and yet you need to extend empathy to other people. So I've gone through these things and have had to think about them and navigate them. And again, I'll share a little bit on that. And also then really finish off around this idea of saying, in this time that we're in, it becomes really important because then we want to rely on science, but science is competing against so many other factors. How do we harness science in that context? So let me start here to say that you would have heard about different models of communicating, and one is the so-called transmission model, and Dr. Nona referred to this notion that you're just sending information. She used the post office as an example. So you're just kind of channeling through a pipeline. Usually it's one directional. And if there is some sort of feedback loop, yes, there could be a feedback loop, but transmission is very technical. The transactional model is the one that begins to say that, hang on, like there's two people here that are engaging. Usually in face-to-face conversations, you're using a transactional model. There's two ways. You start to recognize that actually there is noise around communication. There's feedback, there are thoughts, there is a context, there's an environment around how communication takes place. But I want to really say that let's take it further and start to understand this notion of constitutive model of communication, which a lot of people don't subscribe to. And I don't know the extent to which you as communicators subscribe to this. Because in normal times or in peacetime, you don't often need this idea of a constitutive model. And this here emphasizes the notion of creating. And I'm assuming that when we are in an environment where we don't know enough, we can enter into a space of communication where we are creating knowledge enough. We are closing the gaps together. Is this something that is feasible in terms of communication? Instead of just kind of looking at the gaps and being intimidated by the gaps, assume a different way of communicating that helps you to build knowledge. And in my view, I think what Dr. Nona referred to as when you don't know something, you need to go and find out the facts. You're creating here, you're creating knowledge. It's not a matter of just saying, look, I don't know, and that's it. And also, if you're asking a question and I don't have an answer, that's your problem. No, here you're saying, actually, this is too important, because then it's a matter of life and death. Can we find a way of making sure that we close these gaps? But I want to push it further and talk about this idea. Whenever now you have to create, and generate knowledge. What does that mean? Because a lot of us learn, we get information from different places, we learn, we are constantly learning every day. But we forget that when we were in school, there are different levels of learning that we use. The challenge we have here is if you have to adopt a constitutive model of communicating, or this sort of notion of creating knowledge and closing gaps when you've got so much uncertainty around you, you are now having to engage at the highest level form of creating, of learning and teaching. This is the level that is high, because then at the very basic level, what we often do with information is, here's a fact, you just have to remember it. And we talk about this as regurgitating fact and didactic converse. Most of the transmission models kind of use this. But then we now go further. The next level after that, when you're communicating or you are sharing information or you are educating people, you want them to understand. And then once they've understood, you want them to apply the things that they have learned. Most of us are taught in undergraduate, when we do training, are taught largely to get to a point where we apply the things that we learn. We are often not taught how to analyze information. A lot of the people who now have to look at data and decide, what to take and what not, you're getting at a point where you're analyzing. Above that, you have an evaluation of information. You're judging the value of information. You're putting weight to information. And above that, you're now having to create new information. And don't get it wrong, like when you are taking different sources of information and you're putting them together and you're synthesizing that information, you can go to a point where you're actually generating new information. When there is no information, somebody needs to be able to produce that knowledge. Now, where do you sit? Where do you lie in this sort of, I don't want to call it hierarchy, in these levels of engaging with learning and sharing information? It's something you have to think about. And at this point, I just also want to highlight the fact that, we talk about scientific facts, but it is not so much the facts that we are going to communicate. It is the meaning of those facts that we often have to communicate. And the moment you take a fact and you translate it into meaning, you are already kind of analyzing that information. You can change information in doing that, which is why then it becomes difficult to simplify information. What you see in the video, you're seeing someone who takes a medical jargon of spike protein and wanting to explain it in simple terms. How do you do that and still stay true to the meaning of that word and yet simplify it for someone to understand? And here also the challenge we face is that the people we are communicating to are not necessarily in themselves empty vessels. They are people. A lot of the people that we call ordinary citizens in public health, they're actually professionals elsewhere. They're experts in their own way. You might be talking to lawyers, you might be talking to business people elsewhere. In their own way, they are experts elsewhere. Even if it's a community person who basically does community work, they are experts in their own way. So now you have to deal with this issue of translating knowledge to someone else and providing knowledge or information to someone else. But you're dealing now with a diversity of people. When we say simplify, what does it mean then in that context to simplify? How far do you go? This leads me into this point around what we understand as the goals of communication. And here we know that not all scientists are good communicators, and we must accept that. And we also know that not all communicators are scientists or have a training in science. Now, when you now then have to play that role, when you communicate, what then do you see as your goal? What are you trying to achieve? Are you trying to inform people? Are you requesting information? Are you trying to persuade them in some ways? Are you trying to relate to them or build a relationship with them in some way? Are you trying to entertain? The one area that a lot of people who are communicators say that they don't agree on is this notion of communication with the goal of reforming. And reforming means changing, and this can be quite challenging. Do you subscribe to the notion that when you now engage as a communicator, you're actually reforming, you're changing society, you're influencing a lot more than just persuading information or just changing their mind? Because now when you reform, then you're actually talking about behavior change. And in health promotion, that's what we are aiming for. The kind of communication you're doing in this case is not just communication to provide information, which is why we now say, when you now have the information and you're sharing the information, does it actually in itself translate into someone comprehending or understanding? And if they understand, do they absorb it and accept it as knowledge and own it as knowledge? If they do that, do they turn it into skills? Because a lot of the things, if you now get information about masks, to actually learn how to wear a mask, it becomes a skill. To what extent are you able to then learn that skill and be good at it? And how, when you've got the skill and you know how to do it, do you feel confident doing it? Do you feel that you're doing the right thing? Can you do it in public? And if you now have to do that, can you really change your behavior? Once you know the skill, you've got the confidence, can you change your behavior and improve that behavior in line with what may be required? And if you change it, can you make that a habit? And if you make it a habit, are you then able to advocate with other people? And there's a whole theory behind these statements. They seem like simple statements, but actually these statements are very much about these notions of theories around efficacy, theories around agency and collective agency. They inform these kind of questions when we structure messages. Now, we've spoken about constitutive model, which talks about creating and creating together in the way that I see it. But if we now add and accept that communication needs to reform behavior, reform lifestyle, when you're asking people to go into lockdown, this is so much disruption in people's life. How do you then communicate in such a way that they can transform their lives, transform their lifestyles or behaviors? And I draw all of my understanding largely from health promotion, and the Ottawa Charter is quite good at helping me navigate this. And if you haven't looked at it, take a look at it, at the Ottawa Charter and the principles of it. It is largely about developing personal skills, but it tells you that for people to develop their skills, you now have to create the policy that assists them. And that's why the regulations become so important. They create the cover for people to be able to change their skills. That's why mask wearing improved so much once we said that it is now law and it's illegal not to wear a mask. But at the same time, you need to create a supportive environment, make sure that masks are available, and you need to strengthen community action. And the question that I keep asking myself is, as we communicate, what are we doing to ensure that we support people to change their behaviors? What do we put in place to create that environment for people to change their behaviors, if that's what we are communicating to the public? In some instances, we actually require reorientation of services. And someone has already asked a question about, we have learned here in this pandemic that we need a public health approach, which is not so strong. How do we get a public health approach when we already have an established system that focuses on treating diseases and curing diseases? Now we have to take a health promotion or prevention approach, but our system is not used to that. How do we reorient our system to be able to do that? So power is involved here. And for me, this is also one of the things that we'll talk about. When we talk about politics and politicizing issues, we are contesting power. Power over people, power within people, power with people. It becomes issues that we have to negotiate, and we have to be honest about it. Sometimes when you are having to communicate and you have to be humble to say you don't know, or to say that I will go and look for the information, it feels like you are giving up your authority. Dr. Nona mentioned this, that it's almost like it's some sort of a weakness that you're conveying. What is happening inside is that you're negotiating power. And you have to be able to know that you're going through this and willingly let go of it. And that can actually cause you further distress. It's almost like you can feel like you don't know what you're supposed to do. But it shouldn't be like that. When we're now shifting models of communication, we are saying, we are moving away from that model where I'm speaking as an authority. I'm moving into a model where I'm co-creating with people. Then I'm willing to share power with those people. And we can talk about collective action in finding information or closing gaps. We saw during the pandemic in South Africa that we started to talk about health versus economy, health and social factors. A whole lot of other factors came into play, and they created this complexity that Dr. Nona also mentioned. And I want to emphasize here that whenever we put in place interventions that affect society at this level, we are going to find that they will affect different levels of people's lives, different aspects of people's lives. We talked about burials in terms of cultural aspects, social factors, economic factors, environmental, all these things they get affected. There is something that I find really important about communicators and the role of communicators, and this is being able to connect the dots, being able to pull information from different sources. And for me, this means that as a communicator, it's also important that you like to learn, you read broadly so that you can draw sources of information from different places. And when we are now in a pandemic and we are doing research and we are teaching, we also have to adapt our approaches. We cannot continue as normal. We have to realize that what we are doing is not just for academic purposes, actually has value for society. We have to redirect our efforts to really affecting society. Personally, I would like that science does this all the time, that we don't really only have to do it to this extent during a pandemic. We saw it with HIV, we needed to do that. But it was even more vivid now with COVID-19. And I hope that we can make this a habit as we move forward, such that we can bring science much closer to policy, science much closer to the public, that we can make this an everyday engagement and be comfortable with it. This is, for me, perhaps the most important slide, as I've already indicated to you. One of the things that I experienced during this pandemic was I kept asking myself, who am I speaking to? Again and again and again. And every time I have to do an interview, I have to write a message, I have to ask myself this question, who am I speaking to? Because when I craft that message, I am directing it at someone. When I put together that statement, I'm directing it at someone. And this question is something that, for me, it's not an easy one to answer, but we must always try and grapple with it. I find that if you, for example, are a government communicator, and of course you have your principals, and if you put your principal in the center, your messages will be directed to the principal, will be crafted for the principal. And if you have a certain kind of audience that you're targeting, your message will be directed to them. I'm sure you're aware of this. But the challenge here is that when we are in a public health emergency, it shifts the audience, it shifts the values, the context. With HIV, we dealt mostly with people who were infected. And yes, it could affect other people. But with this pandemic, you're dealing with almost all of society. How do you now, as a communicator, navigate that? How do you convey the risks and the benefits and the impact to such a diverse audience? And this is where for me, I think that we need to spend a little bit more time, even in engaging. And as you move forward into the future with your work, try to think about how much you understand the audience and how effective you are in directing your message to the audience. Again, when I have to simplify a message, I need to simplify it to the extent that it speaks to the audience that I'm speaking to. I'm nearly there. Let me introduce other conceptual issues and theoretical issues that will help ground you. And don't be intimidated by the words. I'm sure many of you have seen these things, but I just want to explain them in simple terms to say to you that whoever you are, you have your views, you have your position, you are standing somewhere, you've got a way of looking at the world and the things that you see. If you are someone who has been infected with COVID-19, you have a certain positionality. If you have lost a family member, you have a certain positionality. If you are basically doing this because of a fear that you have a certain positionality. Now, trying to understand who you are and what you stand for, because you have to do it for your audience, but you also have to do it for yourself. Trying to understand who you are becomes really important. We spend a lot of time in public health communication trying to help people understand where they are positioned. And in ontology, we are basically saying to you, what is your view of nature? And how do you see it? You know, we talk about these concepts of nature versus nurture. Do you think that people behave a certain way because it's in their nature to do that, or they were raised to do that, or both? Because if you believe it's in their nature, chances that you would adopt a behavior change approach in your communication are very small. What do you believe? You would have heard a lot of people in South Africa talk about how I know I need to be given my rights to decide for myself. Like, I want to be autonomous. When you put me under lockdown, you're taking away my rights. These are people who are positioned very much around an autonomous kind of positionality. Whereas other people are saying, actually, what is it that is good for everybody? And they are willing to work with the notion of the collective instead of, are you selfless or are you selfish? These are things that you must confront, even for yourself, because then it will come through in what you write. It will come through in what you communicate. And sometimes, even though you may be in that position, you can actually say that, you know, this issue requires for me to approach it, as we said, from a neutral position. Or I have my concerns for myself and I would like this to suit me, but actually this situation requires for me to be selfless. You can do that, but this will test your character. And for me, I have experienced that this pandemic and communicating it has tested my character a lot. You know, when we were upset with the youth because they wanted to go partying and all of that, and all of a sudden, you know, we were worried about them infecting parents and parents dying. And I was just like, but it's so tempting to scream and shout at the youth. But when you now basically try to look at their views, their own views, where they are coming from, and you listen to them, you start to realize what they're struggling with and how they're coping and the ways in which they cope. And you can now speak to them from their perspective. This requires for you to come out of yourself and be able to see the world from the way they look at it. And for me, I think that this happens to all of us. We may not be aware of it, but it is happening to all of us. When we look at information, do we look at it as this is objective truth or this is subjective truth? Or are we saying that, look, it doesn't matter what the science say, what matters is what I believe? These are the kind of things, the ways of looking at information and processing information, they affect us. And we call this epistemology. It's where we are coming from in the way that we look at information, we process it. And it doesn't matter what fact you looked at. The denialism that we see is affected by these things, which is why at some point you will accept that there are people who have certain beliefs, and no matter what you do, you may not convince them to take a vaccine. However, there are other people who basically are in between. And you can, with the right information, the message is crafted for them, persuade them or encourage them or actually help them change their behaviors. So we have this situation where we're constantly asking ourselves, what is objective truth and what is truth that is constructed? It's about realities. What my reality is not necessarily your reality. How do I then speak to your reality when I only really know my reality? When I look at the different realities that people have, people in low socioeconomic status, people in high socioeconomic status, how do we reconcile that in the way that we communicate with the public? These are the things that I'm trying to address here in these slides. Now, my final slide is basically about, second final slide, is basically about these issues that Dr. Nona has already addressed. Is the fact that when we are looking at these realities and we are trying to understand them, from the way we move out of the beliefs and the psychology of it, it comes out in the world in terms of uncertainty, things that we are really unsure, and of course, then cause a lot of panic. And you're required to create hope here. And when you're going to deal with uncertainty, you need to have a lot of credibility. How do you establish credibility? You may not be a scientist, but you can work closely with scientists who are helping you to ensure that there's credibility in your messages. That's how the minister established the MAC, so that there can be sources that provide him with the current evidence that gives it, and it gave the process credibility. Yes, we may criticize, of course we will criticize. It's part of the reality that we are in, the context that we are in. And when we are being criticized, then it takes a lot of humility and empathy for us. And empathy is exactly that process of putting yourself in someone else's shoes. And we have to be really intentional in doing that, especially in an emergency like we are in. And we've mentioned complexities, and a lot of us, as we said, you have your own compass. Sometimes it's a moral compass, sometimes it's a religious compass, or whatever compass you have that basically orient you. And now you end up having to deal with people who have different compasses, and you must try and reach them and connect with them. Now, within complexity, even though we call it, sometimes we might call it chaos, whenever you're in a state of chaos, you still need to be consistent in your messages. How do you achieve that? For us, we have to constantly think about this. Think about, even though the science is complex, how do I make sure that the messages are consistent with what we know? And also when we are communicating to people, we are not constantly giving them conflicting messages. Interest, we've discussed issues of politicization of the pandemic, and we've discussed issues of disinformation and trust deficit. I won't dwell on that, but you've also seen the kind of things that would erode public trust because of interests that people would have. Finally, I just want to say to you that we are in a state where we are navigating new science, and new science can be a good thing, but it can be very frustrating. And if, as a communicator, you are frustrated by science and new information and the amount of information that you get. I mean, the first time I experienced this was with HIV, where there was a constant explosion of new information. But with the pandemic itself, it was almost 10 times the amount of new information that one has to navigate. And it becomes important for us to put in place systems that allow us to process information and synthesize information. And we have to be intentional about that. Even myself personally, I have people who are specialists in other fields of medicine that I work with who help me to process information before I communicate it. We also then have to make sure that even in the leadership style that we have, you need to try the leadership style needs to move into this sort of crisis leadership style that helps us to move out of the crisis, look towards the future. You can't keep doing things the same way, and that adaptation becomes important. And you can see here, we're talking about managing uncertainty, being adaptable, and again, this issue of systems approach. Now, I know that all of this have to happen under the pressure of time, but we must see in all of it that there is an opportunity. You will see that some of the things that have happened during this time of the pandemic are good things. We are now able to have this webinar and have it the way that we are having it. The advancement that we may not have seen if the pandemic had not come. We must not miss those opportunities, and we must exploit those opportunities even in a pandemic, even in a crisis. We have been able to establish new practices, new cultures, new innovations that come in many different forms. It's not just in terms of a scientific paper. They come in many different forms, and we have to take the opportunity in harnessing them. Let me pause here and then allow us to get into a discussion. Thank you so much.
Thank you very much, Prof. Mashibela. I think in the spirit of discussion, I'd like to ask, there's actually a flood of questions and comments. So I'd just like to add more voices. Marika Champion, if you could enable your mic and ask your question. Marika, are you there? Okay, perhaps not Marika. Joyce Sukumane, if you could ask your question. Okay, let me ask the questions on their behalf. So somebody had commented and also asked that there's a public perception that once one has contracted the virus, following recovery from it, you develop immunity to it. Unfortunately, there might be a possibility of a third wave. How do we as communicators disprove such perceptions?
Do you want to do a few questions, or do you want to go through it one by one?
Okay, that's fine. We can do a few at a time. Another question, does the antibody resulting from one being infected make it unnecessary for one to be vaccinated? And then directly to you, Prof. Mashibela, what lessons can you share with regard to communicating with young people, as we have seen spikes of new COVID-19 infections at several institutions of higher learning? I think that's 3 questions. Maybe we can just take those, and then I will ask others to come in and ask their questions.
Okay, so thank you for that. Let me start, Dr. Nono, and then you can add to that. The first thing I want to pick up on is the point also raised by Dr. Nono to say that we will have multiple variants, mutations, we will have multiple waves. I think that a more diplomatic answer from me would be that, you know, we don't really know for sure what will happen. We cannot really predict the future. But in the spirit of honesty, and I will say to you that we have been learning a lot. I can tell you that when we came out of the first wave, we did not expect the mutation that happened for the second wave. We did not expect that. And also we kind of knew that we may have a second wave. We knew that we may have a third wave. But again, we did not think that the variant could actually drive the second wave the way that it did. We don't know whether the third wave is going to be driven by a variant. It is possible. But when we developed vaccines, we developed them initially based on old variants. Now, if you think about it, the main issue here is how do you balance, and again, this is where we talk about complexity. How do you balance the way the virus is evolving and growing with how we respond to it, with the technologies that we have and the science that we have? It's a good thing that in South Africa, we did a lot of science to study the virus and how it evolves with the so-called genomic surveillance. Otherwise, we would not have known. And this became really important. So that is important in itself. The second thing about how we are responding, because on the one hand, we've got the virus, on the other hand, we've got the response, either in the body or in the country, in the system. One of the reasons why we've been agitating so much around vaccines is for that reason. Because we are hoping that as soon as vaccines are available, we can suppress the virus. The virus doesn't like to be suppressed. When the virus is suppressed, it will evolve. But we do need to make sure that as many people are vaccinated so that they have the immunity that will help them not get infections. But We can have breakthrough infections because of variants. That's possible. But at least we will know that and we can direct our efforts towards that. That's why there is a possibility that we may have a pandemic that carries on a little bit longer than we have reached the so-called herd immunity or population immunity. So we must expect that. But on a larger scale, it becomes really important that people have the immunity that is lasting. When you have immunity from infection, it doesn't last. It lasts about 4 months. And it becomes important to explain that to people. But when you've got immunity from a vaccine, it lasts a little bit longer. If you've got a vaccine that protects you from variants, that's even better, which is why we are now already talking about the next generation of vaccines. For you as a communicator, it becomes really important that you build a relationship with people who can help explain these things to you. Because whenever they are written in scientific terms, and there is a lot of uncertainty around them, people can actually end up making a mistake of interpreting what is being provided. And now you have to simplify that language. So I would say to you that make sure that you have someone or a group of people that you can count on. To have everybody who communicates, they have this. Even I have people that I work with who are helping me interpret the science from different fields. So make sure that you have that. And that for me, I think that is something you may want to set up early on, even if it's someone that you can relate to. You see, if you look at journalists currently in the mass media, that's what they do. Some of us appear regularly on the media, not because we are doing more of the science, but because we can basically just speak to the science. And journalists would then establish that, okay, this person can speak to this one can speak to that. And whenever there's new information, they can quickly go to that person and say, this is the new information on ivermectin. How should we make sense of this? And once you provide that interpretation, they're then able to communicate it to everyone. And I would advise that if at all possible, whenever you have to deal with the rapidity of the science that you have to deal with, it's because it becomes important to have people that you can count on who will help you synthesize information. Under normal circumstances, I would say have a unit that helps you to do that, but that may not be feasible. So just the last one on young people, I think that for me, I got to a point where initially I was frustrated with the notion of young people and their engagement with the pandemic. But I got to a point where I actually started talking to people and asking questions, trying to understand what the issues were. And some of them were honest enough to express their emotions, their feelings, their frustrations, and how they're responding. And what they needed was someone who can extend empathy and understanding to them. And so I ended up taking the risk of basically showing empathy towards the youth, trusting that when they have someone who listens to them and understands where they're coming from, they will then slow down and start to listen to us. And in many respects, I received a lot of positive response from that. And for me here, I don't necessarily have a silver bullet solution, but I really do think that the challenge is that as adults, we misunderstand the youth and where they're coming from and their frustrations and struggles. We think that they don't have problems. They must just do as we tell them. We use a transmission model of communication. And I'm asking that we use either a constitutive model or we use more of a transformational model with them, a people-centered model with them, even the youth as well. Let me hand over to Dr. Nona. Thank you.
Thank you very much. Dr. Simolila, there was a question for you based on your presentation. What exactly made communication of COVID-19 ineffective by attending to also alerting everyone to wearing a mandatory mask? Excuse me. There's also another question to you, Dr. Simolila. How can governments be encouraged to depoliticize pandemics? What role can communicators and media play in this? How do you also measure this against the Bill of Rights that guarantees freedom of speech? And then lastly, how do we know that information or COVID-19 vaccine awareness coming from the World Health Organization is legitimate?
Okay, thank you, Natasha. Let me start with the last one. When we were alerted to the early development of this pandemic, I'm sure everybody knows that it was in the province of Wuhan in China, where this whole pandemic started. We convened the biggest number of scientists, I think, 3,500, I think, if I remember correctly, on a platform. It had to be a virtual platform because many countries had closed their borders by then. And we put a number of challenges to them. Firstly, I think a lot of people know, or, if let me just share this information that, many researchers do trials in groups, small groups, big groups, in consortia, as it were. You've seen the researchers here who are working on Johnson & Johnson vaccine. It's not a lot of people. So we proposed and recommended to the scientists across the world to share, to not all go off and do this alone, because it was going to take us more than 10 years to get to where we are now. So we asked that they follow a particular protocol that enabled us to compare apples with apples, oranges with oranges, et cetera, et cetera. And fortunately, because there was such a vested and huge interest globally, because this pandemic knew no borders, there was consensus on that. So people went off, they congregated, they formed bigger consortia across, and we wanted these to happen across geographies, like here in South Africa, collaborating with the UK, with Brazil, with whoever, just to see how things were going to work out. Now, WHO is a normative agency. Anything that we put out there is based on evidence. And I can assure everybody on this platform that there are people who never slept in the first 6 months of this pandemic, who were churning out information. We asked for a central repository of all publications. People were going through whatever scientists were publishing. Some were tiny, tiny studies. Others were big enough to draw maybe some conclusions. But through this very big platform, we were also able to get scientists across the board to cross-fertilize their own knowledge and to actually get to a point where, they were exchanging information in ways that have never happened before. You've never seen this kind of collaboration. So even when we came to the assessment of the vaccines that were making headway, all that information we asked, please make it transparent. Otherwise, before you would hear only the day before that here's what's coming up. This one's vaccine is 90%, has a 90% efficacy or things like that. But we have a transparent platform where you can see the race. And on that platform, you've got the name of the manufacturer, who has bankrolled that vaccine, who invested in it, where are the trials happening, how many people have been put on the trials, what are the phase 2 trials saying, what are the phase 3 trials saying. So we really, like I say, hand on my heart, I can vouch for the integrity of the system and of the fact that what we've put out there by way of knowledge on these vaccines is as credible as we can get it. And where governments and or researchers have not given us the information, and there are instances like that, we are unable to put their vaccines on the list, because first of all, you've got to submit your information, and then that's step one. The second step is that WHO personnel who are experts in this area must then visit the site where you are producing this vaccine to see if you are following good manufacturing practices. So there are some countries that refused us entry into their countries. So that already creates red flags in our heads, and those don't get put on the list of vaccines that can move forward. So we've got this information, but as I said, and as Prof said, in the face of uncertainty, you always have to keep looking, digging for anything that's new, that's out there for us to use and or to evaluate, to strengthen the evidence or refute what other people have claimed. So that's where we are now with the vaccines. The second question that you asked that took so long with this one, what was the second question, Natasha? And the third one, so I can just go one fell swoop.
Sorry about that. The second question was, sorry. How can governments be encouraged to depoliticize pandemics?
The sad reality about WHO is that we are a member state-driven, member state-led organization, which means we cannot impose things on governments. We can only advise, strongly recommend, and speak openly, like you have seen Dr. Tedros do on the platforms. I'm sure you know we were under incredible pressure by the previous US administration, and that was really because of the relationship with China, that we hid information from China, and we did this and we did that. So it's difficult. You can't say to the president of Brazil or prime minister or whoever, this is real. You can't tell your people to, drink hydrochloroquine or wash with this, or, this is the thing is we are strong on the evidence and the normative guidelines, but we don't impose, So in normal parlance, you would say we don't have the teeth to force governments to do something. That's why, the words that have, or the word that the DG uses is solidarity, share, don't leave others behind, do the best that you can. But we've seen that governments that did not take the precautions, sadly, the populations that suffered were their own citizens, unfortunately. So, not politicizing is a difficult thing to call out, because as I said, in my earlier presentation, there's a lot of money in this pandemic. Sad as it is, many people are going to be super rich at the end of this pandemic, and those interests sometimes trump public health. That's the bottom line. That's the reality of our lives, the reality of our situations. Like I say, how can you, with a population of 26 million people, pay ahead of time for 150 million doses of vaccine? What sort of government does that when there are other people across the world who are poorer than you are and who've got nothing, So it's, for me, looking at what happened with HIV, it's playing itself out in the same way. Remember how long African countries were denied access? Some people even said that, we can't take treatment because we can't read the time. There were some such ridiculous things. So this is the reality. This is where we are right now. and we just continue to plead for solidarity. There was a question I saw about, I want to just add additional information onto what Professor Mosa said, is that, from the initial knowledge that we gathered before the emergence of these numerous variants, we knew that people who had been vaccinated got, the antibodies, or who had the infection got antibodies, but that we couldn't tell how long those antibodies lasted in their system. And the same question has arisen in South Africa to say, what are we going to do with people who have recovered from COVID? Are we still going to vaccinate them? And the response that we are recommending the government should take is to say that, given the supply constraint with vaccines, we would like, or we recommend that those not be prioritized in the first groups of people that are going to be vaccinated. So, you play with what you've got, but the balance should be on the well-being of the recipients of whatever it is that you want to give to the clients.
Thank you very much. I'd now like to ask one of our panelists to please go ahead with some questions. Thiessen Moodley. Thiessen, are you there? We can't hear you.
Thank you so much. Thank you so much. Can you hear me now?
Yes, thank you.
Just a few thrown in. There's some comments and questions thrown in. You will find that when you're dealing with communicators, we are not like scientists. There's a whole lot of thoughts and things that run through our minds that we afterwards try and put it in a straight pipeline. The first one that I want to bring about is, you see, at the end of the day, we are government communicators. We are communicators, but based in government. So our key messages involve service delivery by government. It is hard, very hard, to create an awareness of a pandemic when the first thing on people's minds is service delivery. What I'm trying to get at is, we are in a situation where there are much more pressing needs if you look at it from the minds of the communities that we serve. Hence, this is just a comment that as a province in KZN, I'm from the Department of Human Settlements. We looked at, because it's a learning session as well, it may be a good comment. We looked at an angle that we should adopt for the messaging going forward. And as much as we speak about a first wave and second wave of the virus, we said, let us also speak about a wave of service delivery, a wave of delivery. So it's about bringing two matters, aligning them, and showing people, yes, our people, that we care. We're not only focusing on COVID-19, but there's delivery as well. That will enable the trust issue to be sorted. Because I think the greatest problem that we find as communicators is not in the messaging or the content of the messages. It is the reception. It is the impact of those, whether they've been taken to heart. And it's difficult if the environment is not right. No matter how creative you are with your messaging or the tools that you use, the impact is not felt. So what we've decided on, this is something catchy, is that for all our posters, all our messages, all our social media, the narrative that we're creating is zero tolerance to COVID-19, but 100% commitment to service delivery. In one breath. In one breath. That is the narrative that we've adopted for our MEC's budget speech, the narrative for our advertorials on service delivery. I'd like to stop on that point because I tend to talk a bit too much. That is the one comment. A question would be, when we are engaging with the public, we need to be, as you say, we are communications, we're not scientists. Why is it reported as the cause of deaths to be COVID-19 complications and not COVID-19? because that leads one to believe that the focus should be on underlying conditions and not on the virus itself, if the cause of death is COVID-19 complications.
Thank you very much.
Thank you.
If I could also ask Mr. Mandla Radebe to also ask his question.
Thank you very much. I hope you can hear me. You can hear me?
Yeah.
Yes, we can hear you. If you could maybe enable your camera as well, please.
Sorry, I'm sitting in a position where it will look very bad if I enable my camera, because I'm also using my iPad, but I'll try my best to record myself so that I don't look as unprofessional as I may appear.
Okay, thank you.
But I'm using my gadgets, not my laptop. So if it moves, you tell me. Briefly and quickly, my point I sought to emphasize was that how we anchor the messages and the discussions that we are trying to do should not be devoid of the contextual reality that the majority of the people we seek to drive the messages to find themselves. I think must be alive to that reality. Let me give an example. Is that some of the messages we drive on the preventative messages, wash your hands, social distance, are not practical in a vast, for the vast majority of the people who find themselves where they are in informal settlements and so on and so forth. So the socio-economic reality should be our starting point if we are going to drive effective communication. So we shouldn't be abstract in the manner in which we drive these messages. So it is my view that the major issue for scientists and communicators alike is how do we ensure that these professions interact with society, and appreciate the fact that the pandemic is spread between people in communities, in workplaces, in public transports, and so on and so forth. So at the heart of the problem, as far as I'm concerned, is how do we make sense of the problem in the context of our socio-economic reality. I think for me, that's a major point I thought we needed to drive, rather than being abstract, because the problem is not a scientific problem per se. The problem is a socio-economic problem that we need to address fundamentally in South Africa. Thank you very much.
Yeah.
Thank you. I think perhaps you can share the questions between yourselves, Prof, and Dr. Simolila.
All right, let me go first. She can wrap up. So I will also just kind of address a few that I've picked up. Let me start with the first question from Thurston, that I quite like the approach of waves of service delivery. But what I'm hearing from that, and I'm interpreting it from what I'm understanding you to be saying, is that you have now moved out of a crisis mode of responding to COVID-19. You are now kind of getting into a phase where you're trying to make sure that you're getting into the maintenance phase, which means that you are having to not neglect all the other things you have to do to now bring them on board. COVID-19 is here for long. It wasn't just here for 3 months where you can stop everything else, focus on it, and then it's gone. You're now having to learn to live with it, to work with it. And now that's why you're having to make sure that even in dealing with COVID-19, you are making sure that you're still meeting your tasks of providing service delivery. And if that's if that's a correct understanding, I think it totally makes sense. And it's important that you adapt. And that's why we're saying that you need adaptable structures, and leadership needs to be able to accommodate that. However, in doing that, it becomes important that you do not necessarily simplify things, whereby you're trying to just focus on doing what you know you're supposed to do or what's familiar. You also have to do waves of service delivery in ways that are new, that accommodate the fact that we are in this reality of COVID-19. Hence, the idea of no tolerance also makes sense. COVID-19 complications is different from COVID-19 risk factors. So the underlying conditions, when we say underlying conditions, usually we are referring to risk factors. You will not see that someone died of COVID-19 risk factors. You will see complications. And complications, so risk factors are the ones that would expose people to either COVID-19 or severe COVID-19. Complications are the things that the diseases that would arise because of COVID-19. COVID-19, the SARS-CoV-2 will infect a person, go from the lungs, start going to other parts of the body. COVID-19 was defined mostly as a lung disease, but the receptors that are involved, the ACE receptors that are involved, that SARS-CoV-2 are attached to, can be found in other parts of the body. So it would spread to the kidneys, it would spread to the brain, it would spread to the muscles, to other parts of the body. So some people then die because of this multiple organ damage that then happens. And so clinicians then struggle to confine it to lungs. It's not just pneumonia, it's not just neurological problems, it's not just kidney failure, it's like multiple organ failure. So that's why they then say COVID-19 complications. It's also a way of acknowledging the fact that COVID-19 itself can be self-limiting because it's a virus, can be self-limiting. That's why some people recover, but then other people will go on to suffer complications. That means that they've gone beyond what would be the standard part of self-limiting disease. They've gone further. So those things might be helpful for you to understand, but it is a good question. In terms of the Manda's question around socioeconomic challenges, I agree with that. But I think that, Manda, as I said, in as much as when we communicate, we try to make things simple, it is important that when we are looking at a complex problem, that we don't try to simplify it. This is very difficult because as humans, we like to simplify things, but some problems, we need to see them in their complexity and embrace them in their complexity. It's okay to say that, you know, this is a COVID-19, it's a biological problem or biomedical problem or a clinical problem. But then it will affect a person socially, it will affect a person economically, it will affect a person in other ways. And embrace the fact that there is complexity, which is why I was saying to you that as communicators, my view is that you are also people who connect the dots. You know, you have to be able to see the relationship between different things. In society, the way we are trained in one particular field. Scientists, a lot of scientists are trained in one particular field. So when they speak in one field. You don't find a lot of people who speak in different areas. You'll have an economist there, you'll have a social scientist there, you'll have an epidemiologist there. They don't necessarily speak in the completeness of the problem that is complex. But as communicators, I do think that you then have a challenge to connect those dots. Let me just address quickly the issue of efficacy, effectiveness, and efficiency. I think that in simple terms, what is important about these concepts is that these are concepts that we use to do tests to see whether things work and how well they work, generally speaking. And you just have to understand it, that's basically what it is. Now, there are different stages of testing. The first stage you would test, and then when you test, it's either in a laboratory or in a controlled environment. And we often say here that you're holding all the other factors constant. So as Mandla was saying that, you know, there will be socioeconomic, there will be social, we hold all the other factors constant to try and understand one problem or one intervention. Then when it works in that environment, we say it's got efficacy. Efficacy means that it in itself, it works. In and of itself, it works. But then when you now put it in the real world, you now talk about effectiveness, because then you are allowing other factors to come into play. And sometimes, for example, if you take a drug for ART, you know, ART might work, but if you don't adhere to medicine, it's not going to work as it could. So that's effectiveness. The challenges that would make people to adhere to treatment. So in the real world, we're talking about effectiveness. And that's why when we now put the Johnson & Johnson vaccine and other vaccines in the real world, we started talking about their effectiveness as opposed to their efficacy. that we did in the clinical trial. Efficiency is where you account for cost. And it can be cost in different ways. It can be cost in time, cost in money, cost in different ways. But those are your efficiencies. So something works and it works in the real world, but then does it actually save us money? Because you might have two things that both work, but which one is going to be more efficient becomes the question. And those things, they help you in policy decision-making and as you draw up guidelines. Lastly, it's about the 90% recovery rate. The 90% recovery rate or 95% recovery rate, it's important to understand when you actually see the general patterns of viruses. And you would have had a lot of tensions around comparing flu to SARS-CoV-2, to COVID-19, in terms of the extent to which one virus will have a population impact. And we're looking at it at a population level. Now, I am very pleased, and I've said this many times, that we did not expect South Africa to recover from the second wave with that aggressive variant, with the tools that we have. We did not expect that. We were not seeing that in other parts of the world. But it was impressive that we could do it at alert level 3 with few additional restrictions and enforcing masks and bring it to the level that we have brought it. And here I want to emphasize one thing. You know, when we talk in public health, we talk about combination intervention. And again, this addresses this idea of looking at an intervention broadly in its different components. Sometimes you're not just using masks when you're doing a public health intervention. You're combining masks, you're combining hand hygiene, you're combining it with some restrictions here, you're combining it with something there. That's a combination intervention. You're restricting alcohol there. That's a combination public health intervention. And so it means that you've got multiple components of an intervention working together, coordinating, synergistically working together. And that's okay. And we don't have to fuss about the one part that actually makes all the difference. No. Yes, you know, something would work for certain people, another one would work for others, others would work for different people. But when you now combine it, you see this positive effect. And so this is what explains the high levels of recovery rate, because we know when these things are not taking place, like you would see in Brazil, the pandemic gets worse. And believe you me, the pandemic in South Africa can get worse. If the citizens were not necessarily cooperating to a large extent, not necessarily everyone, it doesn't have to be everyone. It just needs to be a good sizable size of the population cooperating. That's what makes the difference. But we know it's not completely sustainable. And so that's why we want to make sure that we bring in vaccines, and we were pushing that vaccines, people know when vaccines are coming so that they can stay hopeful and continue to cooperate. I hope that addresses the question of how we were able to achieve those high levels of recovery rate and not to take them for granted. Thank you.
Thanks, Prof. I think on that note, if I can ask Dr. Simolila, if you could give us your closing comments, and then we'll hand over back to our DG.
All right, thank you very much. There is one specific question that the principal asked me to respond to, which is of interest to all of us who live in South Africa because of the high HIV prevalence. And it will, everybody expected that, you know, we were going to be wiped out as a country because of HIV as such. But I can safely say, you know, and this will emerge in the analysis that we will put to accompany the rationale for why we are going to roll out the vaccines in the way that we are going to roll out when the minister announces the plan. When the researchers looked at comorbidities, what was actually very fascinating was that in South Africa, although we knew from information from other countries that age plus comorbidities were the highest risk factors we also saw the same, I think, in our country, where people who had comorbidities seems to be at a higher risk of contracting COVID-19 and also, progressing to death, as it were. But they did an analysis and they actually looked at everything, all the parameters, odds ratio, they did regression analyses, and they actually found that in addition to age, the first comorbidity that seems to be very pertinent to South Africa is diabetes. Hypertension was low in the list, and HIV was low, much lower than we even expected. And that is the result, as Prof. Musa keeps saying, of having the tools, having the analytical ability by way of the pool of and expertise of researchers we have in this country, who've now looked at the South African situation. So we can comfortably say, we obviously don't want to minimize the fact that people have HIV and are on medication. But if I was to give you a hierarchy, I would say age, 65 and older, and then I'd say 65 and older with a comorbidity, one comorbidity that's top of the list, diabetes, type 2 diabetes, and then tuberculosis, and then third, or down, much lower in the list, seems to be HIV. So we have our own information now, which means that even as we deal with the vaccination, as I said, we know now how to prioritize, and this, you are hearing this for the first time. Please hold it until the minister announces it properly. I should actually try and not preempt him, but this is a platform where government communicators are seeking information, so you'll hear it within the next 24, 48 hours. So that is a very important question, which I hope I have answered. There was a question which I think Professor Musa tried, explained or responded to, but I'll emphasize again that even if you've got antibodies, there is no knowledge, we don't have enough information about how long those antibodies last or how long they protect you from getting COVID from another variant. And we have research that has shown us that there are people who've actually had a second bout of COVID-19. So it clearly is probably another variant or something. This virus is really trying hard to survive. So I would recommend strongly that even if you have been exposed to COVID-19 and you've got antibodies, to be in the queue for your vaccination because of the many unknowns that are out there, especially how the variants are reacting or interacting with our bodies, and making sure that they survive and that the vaccines maybe become less efficacious. So those would be, those are the things that came through. A lot of the questions, I think, my fellow panelists dealt with very well. And so I think we are done.
Thank you very much.
I really hope that we learned as much as we possibly can. Sorry, we really overran our time, but this was very important.
Worthy conversation. I think on that note, thank you very much, Dr. Simolila. I'm going to hand over to our principal. Principal, for you to close.
Colleagues, thank you very much, both you, Professor Moshabela, and you, Dr. Nona Simolila. We call each other Sis Nono. Firstly, for agreeing to be part of this conversation this afternoon with government communicators, as well as media practitioners in general and other, interested, parties who have joined this session today. I do believe that, most people will say that this was a useful interaction in many respects, more so because people had been asking some of the questions that we have assisted to answer this afternoon. In fact, I must declare that earlier today from 10 o'clock, we had a session with government communicators where we were introducing the new course the National School of Government will be implementing in partnership with GCIS, meant to empower government communicators. We then recommended to GCIS, and they agreed with other colleagues that we should invite these esteemed guests to come and have a conversation as part of breaking the ice, but also empowering them on this conversation. And there's colleagues in the media who had in fact challenged us to arrange a conversation of this format. I do believe, for my part, at least certainly for me, that people have learned something new today that they might not have been aware of. It's also very interesting that in both your instances, you didn't come and present something that will appear in the Lancet, a typical Lancet type of a presentation, because it might have lost some of us in that regard, but we were able to at least come to our level and try and decode. I suppose because we're dealing with mostly how we are oriented, we're dealing with what our attitude should be with regards to handling scientific information, with the knowledge that this information must land in the hands and the ears of ordinary South Africans who may have their fears and anxieties. I think you did great in that regard. We will be calling on scientists, as you have challenged us to do. Now, the reality is that in the course of the work that we do, we know exactly how the virus, I mean, if we could call it that, has performed here in South Africa. If you look very briefly at the numbers over the past, I would say maybe month or so, you will notice what happened, for example, on the 24th, of March. And I'm picking that date because since that date, numbers began to decline, and we are now sitting on these numbers. We are seeing daily reported cases of 765. And the challenge, therefore, could be that we might soon reach a stage of complacency, as we might have seen, because people think we are recording 365. In the US, they are reporting 60,000. And at times we saw some of these things with, during the HIV and AIDS era, where it was that, the incidence and was high, that people begin to see numbers like these and they begin to be complacent. Of course, the Easter has just passed. So it will be interesting for us to observe these numbers, in the next 2 weeks or so. And I argued that throughout last year, when regulations were changed regularly, that what we need to watch is what happens 2 weeks after the regulations have been changed. Now we've gone through the Easter period. It will be interesting to see, even as some were arguing post the funeral in Wanongoma 2 weeks ago, people were saying that there might be a spike there. I mean, if the spike happens, we will be seeing it this week and in the next week as well, because of the clusters of people who are coming together and so on. And one is using this as a way of saying to government communicators as well as scientists, that data matters to the extent that we should be able to use it to get the public to know better, what is happening. And our intention is to bring a lot more of this type of interactions. As I said, as a National School of Government, for us, partnerships are the future. So those of you who want to do programs with local or international institutions, please do call on us. I have sent our email address on the chat platform. Otherwise, we are generally available, and we'll send you emails, we can facilitate your participation in some of the programs that I'm showing you, here, because I have to do some advertisement as an institution. We've got these great programs that we are that are taking place now through our local and international partners, and we're looking forward to having you participate in this. We've got many more. We've got many more masterclasses that are coming soon. We'll be inviting you to those masterclasses, and hopefully you will find them worthwhile, and that today was also worthwhile. Thank you very much. If all the panelists can just turn on their videos, they are my colleagues who want to take a selfie, and we must have a good afternoon further. Yes, there is someone who has decided to unmute, but we can all unmute, colleagues, and say goodbye. Yeah.
Goodbye, everybody.
Goodbye.
Goodbye.
So all the
Bye,
panelists, you can show your videos. Hello, Nomonde.
Thank you very much.
Thank you very much, DG Pumla Williams. We thank you for helping us arrange this. Thank you very much.
Thank you.
Thank you.
Thank you so much.
Thank you. And thanks to Marty, Kulsam, and other colleagues who did all the great work behind the scenes and bringing us together. Thank you very much to you. Hello, Nomonde, we see you still in church. Good afternoon to you. Great stuff, and bye-bye.